Good afternoon. Thank you, you all. Okay, so we have Dr. Michelle Burke joining us, suicide expert from Stanford University, and we have Dr. Pia Santini, who we heard from earlier today from UCLA, and Dr. Shashank Joshi from Stanford, and Dr. Walter Kay, University of California, San Diego. And here we are on this panel. So I'm going to try to get through questions because there's an array of questions and topics. But one in particular that stuck out to me is, I'm not going to read the whole question because it's quite long. It's from a woman who's a grown professional woman now. She was diagnosed with ADHD as a child and took medication for quite a few years in order to manage the ADHD, and then stopped later in life when she got pregnant and started to have kids. She's doing fine now, and she just wonders. People are curious about the effects, not just for ADHD, but the effects of medication over the long term, and if that's something we should be concerned about. Let's see. You want to go with that?
Well,
okay.
I'll take a start. So I'm going to channel Dr. Hinshaw here.
Please, yeah, thank you. Yeah.
So there's a couple of pieces about medications to treat ADHD. First of all, they're not all of one diaspora, let's put it that way. You know, there are stimulant medications, there are different types of stimulants, there are non-stimulant preparations. And for most children and adults with the condition, even for those 50 to 75% who will continue to have clinical symptoms into their young adulthood, they're not taking medicine every day, particularly for the stimulants. So we don't have a study that can longitudinally say, over the course of 10 or 20 years, they took the medication every single day and compare it to a group who did not take the medicine or who did. It's very hard to have that study. I mean, the MTA is trying and tracking people over many, many years now. So we have this system of classifying medications according to the specific medicine and whether there have been studies in pregnancy in humans. Okay, so that's the other part of this is some of the data that comes out saying, okay, you may use it if the benefits outweigh the risks, because there may be a risk. And when you read the fine print, it's often, well, based on studies done in rats and rat pups or mice and mice progeny, there may be a higher risk of, name the drastic condition. Mm-hmm. So I guess my simple answer would be, we don't know in a particular patient with a particular medicine class, but we can look at the potential risks in an individual patient and look at the benefits and make that judgment. And that is something we are supposed to do as pharmacotherapists. And I would love to get Dr. Pelayo's take on this as someone who probably is dealing with similar issues in sleep medicine. But that would be my take, not only as a clinician, but also as a father of someone with ADD who's been taking medicine off and on for several years.
Thank you. Anyone else have any of you online have any thoughts about that question?
We certainly have diseases where we use stimulants for a lifetime. For example, narcolepsy. It's a disease where it's a lifetime use of stimulants. So it is something that we have to do. So again, the issue is always the diagnosis comes before the treatment. So for me, make sure we have an accurate diagnosis before we focus on these medications on the long term. But there are new options too, so we can use these things long term.
And that question often comes up with, for you, the suicide experts. I know, Dr. Burke, you're joining us, but you know, long-term antidepressant medication. There's another question about that, kind of the long-term effects of those types of medications. And I think what you just talked about, Dr. Pelayo, is really poignant there about what's the downside of not taking it. So could some of you, Dr. Pia Santini and Dr. Burke, could you talk a little bit about antidepressant therapy and suicide risk and those kinds of issues?
I think the medication issues perhaps would be better addressed by one of the psychiatrists. I don't know if Shashank wants to address that.
Well, I have some thoughts, but I know Dr. K probably has some thoughts too, having seen the explosion of SSRI medicines in the 80s and 90s, especially as applied to eating disorder populations where there may be a lot of comorbidity.
Yeah, medicine is always a balance between risk and benefit, and these medicines always have side effects, and it's just really an issue of kind of clinical judgment and trying to balance it out for each person, following people carefully.
Yeah, I think the tricky part is because the majority of the medication that's used to treat mild to moderate depression and anxiety is in the hands of the primary care provider. We want to make sure that we share the data, we understand what the worldwide data has shown, which is, yes, there are risks of potential behavioral activation and increased suicidal thinking, but these risks are substantially lower, in most cases exceptionally lower, than the risk of not getting treated. And you look at Scandinavian countries and what happened when the black box warning came out in the early 2000s, and you saw rates of suicide attempts go up as medication prescribing went down. And you can see this, over several years in places like the Scandinavian countries. So what we try to do in a very real world way is to make sure that if we're prescribing medication, we don't prescribe and go on vacation. We prescribe and we're available. We have someone they can call 24/7 if they have symptom A, B, C, or D. And I will share the most common side effect with these medicines in the first couple of weeks is no side effect. And that is coming from a place of authenticity as someone who's been in the field for more than 25 years and as a dad of 2 kids who take medication. And I'll say, yes, I'm very worried about that. I want to know about it. I also don't want to unrealistically burden myself with the worry. If chances are, if there's some side effect, I'm going to be able to call someone to talk about it and see, could this be from the medicine? Could this be something else? And so again, it gets back to that individual patient, the dose of the medicine, and how frequently we're checking in to make sure that we're monitoring that. And then, as Dr. Pelayo said, comes from a good diagnosis. First, we're making sure we've got a good assessment and that we've made the proper diagnosis and we've made the proper, what we call formulation or case conceptualization, that always has to precede the prescription. Prescription is never prescribed in a vacuum, devoid of a relationship. There's a therapeutic relationship with your doctor, whether it's a psychiatrist, pediatrician, it might be a nurse practitioner. It's very important for the family to feel, I can call that doctor if I have concerns. I know they're mainly my teenager's doctor, but they get me and my concerns from my point of view. I know they'll answer my questions. I'm not going to ask about what they talked about in the session.
Yeah, and that may be one thing that parents can look out for to make sure the accessibility of the physician prescribing physician in your primary care. Dr. K, were you going to address that?
I was just going to mention, I think one thing that's kind of under-recognized is that the systems that these medicines work on, like serotonin and dopamine, have age-dependent, very powerful changes in receptor function over the course of, development and age. And so, people's response to them and side effects may change over time as these natural kind of changes occur. So it's just a question of careful, observation and follow-up.
So we had 2 questions asking about some specifics about
LGBTQ,
thank you.
IA youth, or a simpler term could be sexual and gender minority youth.
Thank you. Yes, and particularly these questions were particularly about transgender youth, and each of you panelists has a unique perspective of mental health, of youth mental health. And we've actually talked about with some parents at AIM, we've talked with some parents who have transitioning children, and we're thinking about actually having a session about the multiple complexities of mental health and actually mental wellness that often follows a transition. So could you speak a little bit to that? Because there are a couple of people in the audience who are particularly concerned about supporting their transgender children, and also as a society and as a community, what we can do.
Well, I'll take a first comment because we know that transitioning youth in particular have a higher risk for self-harm and suicide, especially when they are in a community or in a family where they don't feel affirmed or validated. And even though in Northern California, we sometimes, we say we live in a place where there's a lot of acceptance of who you are as a person and who you want to be, and we're going to celebrate you. It's not easy for parents to know how to support, what to say, what not to say, how to talk about it with friends, how to talk about it with their kids, how to really listen to their young person's story. So I think it's difficult to know exactly what the right answers are, but it does have to do with connecting with other parents and making sure the young person who's transitioning is connecting with other people who might be transitioning. And part of the process of going through the transition is being in psychotherapy, and going through the transition can be a bumpier road for some than others, and it has not only to do with your own personal experience, but where you live and how you feel you can talk about what's going on with you or not.
And find others. It's
Finding
sometimes-
others,
yeah.
yeah. So I applaud AIM's effort to bring that together, and again, we appreciate the shout out from Dr. K for the work going on at Stanford and UCSF for eating disorders, and there's also really substantial, important research work happening on the neuroscience side and the psychotherapy side about transition, about the process at both Stanford and UCSF. So I think you would have a lot of people you could convene
Yes.
for
Oh,
such a
yes.
conference.
Yeah. Uh-huh. Any ideas, thoughts?
Maybe Dr. Burke, you might want to talk a bit about your experience in DBT. Did Dr. Burke get introduced, by the way?
Not officially. Dr. Burke, could you tell us a little bit about DBT, about dialectical behavioral therapy, and your work? I'll give you a little bit of time just to share about your work with DBT and in suicide prevention.
Sure. Unfortunately, I wasn't able to give a talk, but I can give just a very brief overview. My area of expertise is something called dialectical behavior therapy, which is a treatment for youth as well as adults who are engaging in repetitive non-suicidal self-injury or have attempted suicide. And the idea of DBT is based on the premise that when people become suicidal or harm themselves, generally that self-harm is being used as a coping skill for managing very intense and painful negative emotions that the person does not yet or at the time have more effective strategies to manage. And so the self-harm behavior becomes a way to lessen their emotional pain. And DBT is a comprehensive treatment program that includes individual therapy and skills groups where teens as well as their parents come together and learn many different coping skills designed to help kids regulate emotions safely and to learn how to be assertive and use interpersonal skills to get their needs met and to improve their lives in ways so again they're not dealing with painful emotions that feel so overwhelming that self-harm becomes the last resort for managing them. DBT is right now the only treatment for suicidal youth that has been replicated, meaning it's been shown to be effective at reducing self-harm in 2 different randomized controlled trials. So despite the really urgent need to help reduce youth suicide rates and rates of suicide attempts and self-harm, we don't have a lot of tools just yet in terms of psychotherapy approaches, and DBT is the one right now that has the most evidence for it.
Can I back up just a little bit? Can you differentiate, you talk about non-suicidal self-harm and suicide. People sort of conflate those a lot, I think, in their thinking. So could you just kind of clarify the difference for parents who may
Yeah,
think that's a
it's
suicidal
confusing.
act? Yeah, yeah.
I think
Thank
the
you.
field has been confused for a long time as well, and I think it's important to be clear on what the definitions are. A suicide attempt is some potentially self-injurious behavior that is done with the intent to cause one's own death, and that someone can be ambivalent about that because most people are, but at least part of them has engaged in a potentially harmful behavior to themselves because they want to cause their own death, whereas non-suicidal self-injury is self-harm that is done for other reasons. So the person is not intending to cause their own death, but it often is used to regulate emotions. When people talk about feeling numb or feeling like they can't feel anything emotionally, sometimes they will engage in self-harm. Some people use self-harm or non-suicidal self-injury as a sense of self-punishment that somehow gives them a sense of relief if they're having feelings of guilt or negative thoughts about themselves. If they punish themselves, that temporarily gives a sense of relief. But the most predominant reason for non-suicidal self-injury is emotion regulation. And the behaviors are linked. So, there was a time when people tended to dismiss non-suicidal self-injury as not being very serious or using sort of kind of judgmental or pejorative terms like self-mutilation or a suicide gesture, meaning like a fake suicide attempt. And that's actually, it's not the case that engaging in non-suicidal self-injury really increases the risk of a future suicide attempt. It's a very strong predictor of future suicide attempts. And there's some interesting research showing that sort of in the trajectory of development of all of these types of thinking and behaviors, suicidal ideation usually emerges before someone has ever engaged in a non-suicidal self-injury. So these things seem to go together. So it's important not to minimize the seriousness of non-suicidal self-injury. At the same time, it is a different behavior, and treatment of that tends to focus on what is the function or why is somebody engaging in non-suicidal self-injury, and how can we help them do that in a safe and effective way.
Yeah, and when go ahead, Dr. K.
Yeah, I was just going to say, I just want to state what an effective therapy this is. It's basically the mainstay of our adult program. We have a PHP, a partial hospitalization program. We have a lot of people with, emotional and impulse dysregulation. And our training director, Leslie Anderson, who's a DBT certified trainer, has trained all of our therapists, and she's put in a unique program, which is that if our patients are in crisis, they have this therapist's cell phone number, and they're encouraged to call them 24/7 if they just can't cope with the crisis and they need some help with kind of DBT skills. And that's been just enormously helpful, both in terms of minimizing any kind of self-harm, as well as, it's a really effective time to try and get people to learn and use these skills, when they're in crisis.
So we've talked a lot. Oh, did you have, go ahead.
I was just going to highlight that Dr. Burks talked about the research, some of which she has actually done. Her papers have been celebrated internationally. She's done some of the most important initial and replication studies, and so it's a very important treatment paradigm, which has now been adapted for community settings like schools. There's a whole program called DBT in schools, which is you can get certified in. So really appreciative that she's here.
Can we back up just for a minute, because as you were discussing that, people are curious about what is dialectical behavioral therapy, and what's the difference between cognitive behavioral therapy, those kind of, just in a quick way, can each of you talk about what each of them is and what the difference is?
So I can answer that. DBT is a type of cognitive behavioral therapy in that it teaches different kinds of coping skills and tools to use in the present moment to address emotional difficulties. What's different about it than standard CBT is that One, the focus really is on emotion regulation and the primary role of emotion as being the thing that we're targeting versus perhaps negative or thoughts or cognitive distortions, as one would say in CBT. So DBT focuses more on emotions, whereas some CBT focuses more on dealing with cognitions. Both CBT and DBT focus on behavioral tools and coping skills for managing emotion. DBT is also a treatment package, so it has the individual therapy, the skills group, the 24/7 telephone coaching that was mentioned, and then all of the therapists meet weekly in a team to help support each other in terms of the complexity and the high-risk nature of some of these cases, to give each other support and review cases and make sure everyone is doing everything possible to support these kids and families. So it's a more intensive program than some of the standard CBT models.
And Dr. Piacentini,
I
I was going to ask you.
CBT and DBT are quite different, but I think over the recent period of time, there's been greater convergence. And CBT originally was changing our thoughts. That's the cognitive restructuring, where we actually try to change our thoughts. And I think we've learned, mostly from the adult literature, but we're doing this with children also, it's very difficult to change somebody's thinking or to tell somebody not to think something. We're also recognizing that anxiety, OCD, all these disorders are actually quite chronic disorders in nature. And what we're really doing with treatments is teaching management skills. So more in line with DBT, we're really starting to focus more on helping our patients recognize their thoughts, and rather than engage with them or fight them or try to make them go away, to learn how to better tolerate or manage or just accept them, which is more in line with DBT. And I think the literature shows, preliminarily anyway, that that's probably a better way to go. So DBT really is an incredibly important tool for work even with children.
Thank you so much for that clarification. I learned a lot right there, and I think everybody else did. But here's one of the issues, and this is one of the things that AIM is really trying to address, is how do you find it? You have a child that's struggling, and you're in a panic, and you know about these therapies enough to know that this is what you think you need. How would you, from all of you, really recommend a parent? We know that finding someone that's available, not necessarily the availability, but a couple of questions that parents could ask to someone that could potentially treat their child.
That's a good question. It's really difficult. I think there are so many great therapists and clinicians and programs out there, but I think in all honesty, there are also a very significant proportion of our mental health community is still using tools that may not be evidence-based or as effective as we would like them to be. And our clinic is full. So many of our referrals come in with families that have been in therapy for long periods of time that they haven't found effective. So it's really important for parents to understand what are the effective elements of treatment. My child has anxiety, my child has depression, my child has an eating disorder. What does the science show that's going to be most effective, and really asking these questions. And there are a number of great websites out there. Infoaboutkids.org is one. Division 53 of APA, the Society for Clinical Child and Adolescent Psychology, has a great website to help guide parents through identifying effective treatments. And we have some on our websites as well. I imagine some of the other speakers may. So the first thing is learning actually what works or what is more likely to be effective. And a lot of these resources have clinician directories, abct.org, adaa.org, just among a couple. And the problem is that most clinicians are full. We have a waiting list of 150 kids right now. And we try to cut it down, and then the next week we get a wave of calls, and it's just, there's a real crisis in terms of finding clinicians that have openings. But parents need to keep trying. There are other, there are lower level, there are groups There are apps, there's information, there's self-help. You know, I think the literature is a bit mixed on how effective they are, but maybe better than nothing. While families are on waiting lists waiting to get help. So I wish I had a better answer. From my perspective, I don't. Hopefully the others will.
But questions, you know, really questions that parents can ask to, let's say they actually are lucky enough to find someone who can, who has an opening. What kind of questions? How do you discern?
Well, I mean, when we were looking for a therapist for one of my kids, the one who's struggling with anxiety and depression, it was hard because, you know, I've been in the community for many, many years. How do I find someone who I can go to who will see me where there feels like, you know, it's going to be a good fit? I still ask the same question, you know, what's your experience with this particular symptom? What's your comfort level? What kind of psychotherapy do you do? Who do you work with in the community? If, say, I'm working with a non-psychiatrist, psychiatrists do psychotherapy too, and psychiatrists trained in our program and other programs, they conduct psychotherapy and do it very well. They can prescribe medication and work with families, but often you're seeing either doing what's called combined treatment, which is a better term than split care. Combined treatment meaning the psychotherapy is provided by a clinician who's not a prescribing clinician, and then you may be working with a primary care provider, a psychiatrist, behavioral pediatrician, something like that. So it's important to know. John just shared some really useful websites that hopefully will go out to everyone. But
Yes, yeah.
other strategies, school districts now have started contracting with these nonprofit agencies who act as behavioral navigators. So I'll share one, and I have nothing to do with this organization. I just know they do good work. Care Solace, all one word, Care Solace, SOLACE.org.
We will send these out. We're
Yeah,
getting
so
them all
Care
ready.
Solace
Yes. Yeah.
in San Mateo and Santa Clara counties, they have partnered with the school districts. They basically charge based on number of students in the district, and they act as a behavioral health navigator. Now, what they don't do is they won't say, all right, you're looking for, your child has this, and, you know, they've read Dr. Piacentini's work and all the work that Audra Langley and all the amazing people at UCLA have done, and they want to get this kind of treatment, and there's a wait list. What do I do? Well, I mean, there's something called bibliotherapy where we start with, say, helping your child with anxiety, helping your anxious child as an example. It's based on CBT, but it's written in everyday language for parents to be able to utilize for mild levels of distress to get started. And they will often get this from, so Dr. Piacentini just shared some websites where you can get that information. But the pediatrician, the family doc, the nurse practitioner, they can't manage their very, very large sets of patients with psychosocial stressors, so they have gotten better with knowing what are the resources I can recommend to at least get this parent or family started. You know, with conditions like OCD, parent coaching and getting the parents to be really active as parts of the team, that's really become a mainstay now of the treatment.
And
It's
it's
really,
needed, yeah.
instead of locking parents out, I mean, you need some time with your patient or client, but parents are very much part of the team so they don't unwittingly continue the cycle of anxiety. And then they feel empowered, similar to what happens with FBT and eating disorders. We're giving parents permission back to be parents, but they need some coaching.
The acronyms, we have so many acronyms.
So,
FBT is
like in the case of FBT, family-based treatment
Yes,
for anorexia nervosa.
like what Dr. Kay was speaking of earlier. Yeah. So we have anybody else have any comments about questions to ask? Okay, thank you so much for this input. This is really,
You know,
okay.
this is, it's a little bit harder. I agree this is really a problem because it's so hard to know, you know, to find somebody that you are sure is competent in some area. You may want to know something about their training and whether they're, if they're
training.
using evidence-based treatment, how they're trained to do that. And for programs, it would be nice and useful to see some published data on their outcomes, which is pretty rare to come by, but because most of these programs don't really publish their outcome data. But it really is the Wild West out there.
It's the Wild West out there. It truly is. And so that leads to one of the dilemmas is if I can get any therapist. I've had so many parents say, I'll just find anybody that has a license to treat, and so if you could just, it's the Wild West. You're taking a risk, But at least if we can empower parents with some questions. And I also mentioned earlier that one of the things we're doing at AIM is training parents in youth mental health first aid so that they can be first aiders to their parents and to their children and sometimes their children's friends and all of that. And I know that the governor is investing in really training, especially with CBT, really training lay practitioners to create that safe holding space for during that time when you just really can't find anybody to treat your child. So we have a question. Okay, so these are really, seems like they're directed to you, Dr. Palaio, yeah. How did you know? Did you see the question?
I could read your mind.
See, he can read my mind. That's a little scary.
Yes. I try not to.
Everybody's
Does it distract you when you're reading my mind so much sometimes?
Well, it's like these people who are on the Zoom are people who I want to be when I grow up. So it's like
You want to be Dr. Palaio
I
when
want
you
to be
grow up?
Dr. Piacentini, Dr. Burke, whose office is right next door to mine, and Dr. Palaio, because I'm seeing them for the first time together.
Together
on Zoom.
today. I know,
So-
we have this group for this.
Yeah.
We have the dream team from Stanford today.
Well, I was thinking it was Dr. Palaio because there haven't been a lot of sleep questions, and I think you were bunching them up together.
You're right, he knows. Okay, so that wasn't that hard. You didn't have to go in there to know. You just, great. Okay. All right, so here we go. California, this is from Minnie Elliott. California is considering making daylight savings time a thing of the past. And we've all heard mixed reviews about it. On the one hand, I've heard from depression experts that the extra sunlight could positively benefit mental health. But I've also heard from sleep experts that it'll throw off your circadian rhythms and could lead to more anxiety. We're wondering what you all think about that the extra sunlight, the changing of daylight savings time, on the impact on the mental health of our youth.
Sure.
Dr.
Well, there is
Palaio is
no-
the man.
Here he goes, here he goes.
He's done the work. He's the guy.
Okay,
There is no extra sunlight, right? It's just a question, we're distributing it differently. There is no extra sunlight. We're all unhappy with the need to change the clocks twice a year. What's happening right now is the Senate passed, surprisingly, a bill to put the entire nation on permanent daylight savings time. All health organizations are opposed to this and actually prefer us to go to permanent standard time. Right now, we're in permanent daylight savings time, and the way to remember this, because it can be confusing, is you are basically trading off morning light for afternoon light. But we wake up to light and fall asleep to darkness. So the natural thing for us to do is to stay in standard time. But what's happening is there's a push, specifically by business interests that profit from more retail activity in the after work. So they're pushing for more light in the afternoon. The problem is getting less light in the morning. I showed that slide self. We want all of us, but especially anybody with a mood problem, to have bright light in the morning. The going to permanent daylight savings time as opposed to permanent standard time is you're gonna be waking up to darkness. And in the winter months, people are gonna be out and about, and in some parts of the country, sunrise won't be till 9 o'clock in the morning. When we get involved in these issues related to sleep, interesting bedfellows occur. When we did the daylight savings thing, excuse me, not daylight savings, when we changed school start times, to my surprise, law enforcement supported us because changing school start times associated with decrease in juvenile crime. Now that we're talking about going to permanent standard time, in opposition to what's happening right now in Congress, which is permanent daylight savings time, religious organizations are reaching out to us because there are religious groups that have morning prayers, and they want to do those prayers at sunrise. And if we have less sun in the morning, that shifts the time of their prayers. We already tried going to permanent daylight savings time in the past. During the Carter administration, there was a 2-year experiment to go to permanent daylight savings time, and they stopped after 10 months because of deaths of kids that got hit by cars waiting for buses for school in the morning in the dark. So we agree that we want to stop changing clocks, but we want to go to permanent standard time, not permanent daylight savings time.
Dale,
So
I
I don't
read,
think yeah, go ahead.
I read an article somewhere where somebody suggested, why don't we just split the difference?
Half an hour?
Yeah,
Half an hour,
switch it
yeah.
30 minutes and you get a little more and a little less, or a little less and a little more. I'm curious what you think of that.
I think it's going to be awkward to do half-hour shifts. I think half measures get half results. The reality is when you go to daylight savings time, which is now the bulk of the year, what we're doing is we're giving up an hour. And then we regain in the fall when we go to standard time. And what we're telling our people is, we're going to make you give up an hour of time one more time, and then we won't ask you to do it anymore. We know it's not good for you to change your clock time. There's a study in teenagers that I actually took a slide out, but I can quote, where shifting that 1 hour of sleep, because the circadian rhythms will not allow us to shift our rhythms that quickly, it took the teenagers 5 days to make up that 1 hour of loss of sleep in the springtime that we just had. So the thing we tell our parents and people who ask is, just know you're gonna have a sleep-deprived kid, grumpier than usual. Don't schedule anything that you can, that's not necessary that Monday or Tuesday after the shift of clocks. I mean, half-hour shift, it just feels gonna be weird compared to other places. There are other parts of the world that don't do this at all. And for example, China, and I believe India also, please correct me if I'm wrong, only have one time zone for the entire nation. So we have different time zones here, but it doesn't really make sense to go to permanent daylight savings time because we're really giving up daylight hours in the morning, which I think are the best for mental health. We don't need more light in the evening. They have plenty of sources of light in the evening anyway. Thank you for the question.
Thank you for that question. And you did bring up a lead into another question about how do we compare with other countries in terms of youth mental health support and access to care and things like that. If you know how does the U.S. compare?
U.S. is considered a leader in this field. When California, actually it was the current governor in his first year, the prior governor, Governor Brown, vetoed our attempt to delay school start times. It was Governor Newsom who gratefully signed it into law. At Stanford, we had a research summit specifically about the impact of this law. And many countries started sending in observers, they did it via Zoom. So several countries are watching what we're doing in California as a model for their own countries. Because it is viewed as an international problem, with specifically related to youth suicidal behavior, we're not getting enough sleep. So there should be no doubt that it's good for the brain to get sleep. So anything you do to enhance sleep should enhance their mental health too. So that's the way it's going. England, by the way, in Europe, the schools start there at 9 o'clock in the morning usually, which used to be the time in California.
At 9?
9. And there were some studies looking at changing it in Europe to 10 o'clock, but they thought that was impractical. But if you talk to most people in other parts of the world, they're very surprised how early school starts in the United States. It definitely starts earlier than average compared to most other places.
What about treatments for anxiety, for suicide prevention, depression in other countries?
I'll let others speak to that.
Well, I think for anxiety, I mean, the treatments are, cognitive behavior therapy and variants are pretty well established. I mean, there are some countries that are take this much more seriously and have more nationwide programs. I've done some work with some of the Scandinavian countries, Norway and Sweden, and they have, much larger scale efforts to roll out evidence-based treatments than I think we do, although we're a much larger country. But I think the treatments for OCD and anxiety, most countries have reasonably good programs. It's a matter of how much money they're getting and support the governments are providing to create access. And I can't really address the access, but I know we're not doing a great job here, unfortunately.
Anyone else?
I don't do a lot of international work, but I know that DBT has been adopted in many countries around the world. I don't know how easy it is to find it, but it definitely is being used in several European countries. I think in terms of suicide risk, I mean, there are other countries that do more sort of population level prevention in terms of the obvious access to firearms in the United States, which is different in other countries around the world.
Yeah.
And in Britain, they found a decrease in suicide rates after not making Tylenol easily available to people. And so they've, I don't know what else is going on. That stands out to me as something that was done somewhere else. That would be great if we could do that here. And then obviously the guns are a, problem across many levels of public health that is fairly unique to the United States, and that impacts suicide rates.
Okay.
I feel like one of the silver linings of the internet, social media, is when some of these best practices are published and are shared. More and more open access journals. So I shared Chloe Sorensen's study, which was just published in a peer-reviewed open access international journal. Anyone can read it. Any reporter can download the tool and start putting their articles to the test of that tool. I do think that now with the advent of more, for example, online CBT treatments, some of which are developed for eating disorders, like Bar Taylor's group and others for several years of looking smoking cessation, a lot of these have been adapted now and are being adapted for young people. I think the challenge is going to continue to be, so there's access and getting access to the care, having a phone, a smartphone, even in the smallest villages in developing countries, there's going to probably be access of a smartphone. The issue is, are you connecting with someone on the other side of that device or that screen who really understands you and your story? So young people have to feel that they are understood and that they can connect with the person. They're connecting with another human. They're not just connecting with a bot that's giving them rote stuff to help them in the moment. Now, we've seen the experiment of crisis text line, and there are some automated responses that can be helpful. We also know that young people are exquisitely good. They have a very good bullshit meter. And so if some feel, I'm not doing that, I'm not engaging with a bot, or I'm not engaging with someone who gives me rote answers and doesn't talk to me. On the inpatient unit, we saw people in programs like Dr. Burke's and others, where they, after the pandemic or as we were emerging 2021 with some hybrid model, some students were simply not willing to go if there was not an in-person component. So I think we're going to get better at how to do telehealth over the course of the coming months and years. I do think it's a bit of a silver lining in terms of access, though, because in places where there are very few people who've been trained in some of the treatments you've heard about this morning, there may be options to get that treatment, perhaps even from across your country or in the next country.
Yeah.
We know that there are now digital health-only platforms. Little Otter comes to mind, that was started by Helen Egger from NYU and her daughter, and this is a 100% digital interface. And people their therapists get licensed in 50 states. So they get trained in the best treatments, and then they can scale some of the things that they offer. So I think that may be an opportunity for other places where they don't have as many in-person provider opportunities.
Yeah, that's been a that's a bit of a theme here. It's like the state of the art, the best would be a face-to-face therapist that is well-trained in the particular treatment that is the best suited for your child, right? And then we go out from there, to now we have another layer of the accessibility, to address this accessibility around, around digital health. So this is a couple of people asked about this 4.4 billion that is being put forth by the governor. And I'm just going to throw this out. I changed this a little bit. This has my spin on it. If you could budget part of that, a big part of that, or let that 4.4 billion for impact, let's say over the next 5 years, where would you suggest investing to make the largest impact in youth mental health over 5 years, if you were part of that budget crew that was going to go through that 4.4 billion? What would be the priorities? Anyone in the audience, think about it too. What would you, yeah. I would
Well, I'm
say,
gonna say sleep.
so, okay, Dr. Palaio says sleep.
Says.
Yeah,
Well,
and-
well, it's important.
It's
because
important, yeah.
The pandemic showed there were real issues with healthcare disparities. You need to have a place to sleep, to feel safe when you're sleeping, and not everybody has that.
you got to
So
applause
I
for that.
think
Yeah.
awareness of the importance of sleep, and providing people with safe places to sleep,
Mm-hmm.
are important. And that should have a good impact on how people are living their lives. So with
Yeah.
4.4 billion, a little bit spent on sleep would be nice.
Yeah, so part of the 4.4 billion to spend on sleep, okay. I heard some shouting from the audience. What was someone's, schools? Basic needs, counselors, schools, yeah? Prevention.
I mean,
Yeah, bicycle
Dr.
paths.
Insel shared that slide, health does not equal health care, right?
Beautiful. Mhm.
So it's where you have to look at what are the determinants of health. And social and economic factors in his slide accounted for 40%.
And that's what we heard just now.
Just now?
Yeah, that's what we heard from
Yes.
the audience.
And for Dr. Palaio, he's talking about, well, sleep as an entity and also having a place to sleep.
Mhm.
And so many of these, it's contextualized. But there were a lot of shout outs for schools. Thank you very much. I love to hear that. We published a study last month in Journal of Technology and Behavioral Healthcare looking at a program from a company in New York called Cognito with a K. It's in my references. Again, we don't have any financial connection there, but we do have an interest in this kind of work because it's online, it's virtual, use avatars, and teachers get trained. And in this study, randomized trial looking at 30,000 teachers nationally who got this kind of training compared to a standard training as it relates to having conversations with students. It's about 2 hours of training versus 6 to 8 hours for some of the others that are classroom-based.
The expansion of that to be put into the budget.
Sure.
Yes.
I mean, it's the idea of
Yeah.
empowering teachers to be able to have these
Empowering
more
teachers.
upstream conversations because they are among the trusted adults in the village. We have 65, 70 million students every day going to school. So how can we equip the teachers not only to reach and teach their students as it relates to their academics, but teachers know, by and large, most teachers, they're teaching students. They're not just teaching content. They're connecting with humans. And so they are not therapists, they're not trained to be. However, their conversations can be therapeutic. And they can be trained and they can increase their versatility to know when should I worry, what's normal, what's not, and when should I worry. And that was one of the things in this big evaluation that we did, showing that a virtual online platform can increase the self-efficacy of teachers. They're more likely to engage and ask the hard question and open that box because they want to know, should I be referring? And I'm going to open the box because I know where I have a counselor I can send them to. Now, we may have a long wait list in the community, but I know I have a counselor next period if I'm worried about a student.
Great, we literally have about less than, well, we're a little bit over time, but Dr. K, go ahead.
Just a question, do you think it's worthwhile expanding that kind of training to families as well as staff in pediatric
Absolutely.
offices?
Absolutely. And some of the most important treatments now, space, Dr. Piacentini probably knows about so much of the really cutting-edge frontline anxiety treatments have come out of the UCLA set of programs, where you're really working with parental skill set building to be able to manage their kids' anxiety. And that has been something that's been of interest, but there's more research coming out and more programs that parents can actually participate in now.
Do you have a few words to say about that, Dr. Piacentini, before we close?
Yeah, I would agree. I mean, I think it's so critical we need to change the environments. I mean, that's again what kind of the goal of our center is. We need to train parents and teachers and everybody else that kids come into contact with, because an hour of therapy with a child can be really valuable, but an hour with a parent or a teacher or a coach or a room full of parents or teachers or coaches is going to be incredibly important, because it's really the reactions to the kids. Oftentimes they're going to determine whether their anxiety or their depression, gets better or gets worse, because, the environment is such a powerful shaper. I mean, all the disorders we're talking about, there's a biological basis, but they are all very incredibly sensitive to the environment and the reactions. So I think that's really important. And there are some apps, there are a lot of good apps and trainings out there. There's an app called Connected that's part of a Wellbeing for LA that is going out to school kids, I believe around the country. It's part of the 4.4 billion that's providing kids, in the moment help and also connection to live mental health counselors. So anything we can do prior to the kids going into treatment, anything we can do, early prevention, early education, and that's going to be at schools probably, that's where the kids are, is just going to be critically important.
Yeah, and I think in concluding, thank you all, this expertise, but in concluding, I think what the theme is that there's not one solution. This is not a one-shot deal like, oh, we're going to focus all on this. It's multi-layered, it's multifaceted, it's multicultural, and we have to work at it from so many different levels. And so I just can't, we on behalf of AIM and all of us, thank you for sharing your time and your expertise to really make a difference today. Thank you. Thank you.